Hello, hello. This is Darcy Gaydon recording the sensory neural eye and ear content for CLC. This is a picture of the brain, and I want you to make note of where the visual receiving area and visual interpretation area are. They're basically towards the back. The optic nerve is also an extension of the second cranial nerve, and that is what transmits our impulses from the retina to the occipital lobe of the brain. So that occipital lobe is very important for obviously visual receiving and visual interpretation. We know the eye is a highly specialized sense organ, and we know that impaired vision can affect independence with self-care, work, lifestyle choices, self-esteem, safety, and other social roles. At least 2/3 of individuals that are visually impaired are greater than 65, so certainly as we age, there's a more probability of some sort of visual impairment. And we will also talk about the main leading causes of visual impairment associated with aging, which are cataracts, glaucoma, and macular degeneration. And we'll be covering all of those in this unit. This is just a quick A&P review of the external structures of the eye. Obviously we have our upper lid, you know where the conjunctiva is, and the lower lid, the white part of the eye, that is the sclera. The inner canthus is the inside, and then the lacrimal duct produces healthy tears necessary to maintain integrity of the cornea. So not all tears are bad. They are important for nourishing the cornea as well. Again, the conjunctiva is a barrier to the external environment and also nourishes the eye. Nutrients and antibodies are provided to the cornea by the conjunctiva. So we can pull the eyelid down to examine the conjunctiva, and especially for patients with jaundice and or when we get to pink eye, which is highly contagious, that's where we'll see it to be reddened initially first. This slide is showing more of the internal structures. Again, we don't have to memorize all of these, but I do want you to make note of the 3 layers. The outer layer is a fibrous protective layer that is your sclera and your cornea. The middle layer is very vascular, and that contains your iris and your ciliary body, or the choroid. And then the innermost layer is the retina, which is the back of the eye. And the one thing that we'll talk about with glaucoma, for example, is the anterior chamber, or that where you can see like the big middle area, the ciliary process. And there's an angle that we want the fluid, the aqueous humor fluid, to flow. So we'll be looking at some of these pictures. This is also how they will measure intraocular pressure. The normal intraocular pressure is 10 to 21, and so we will see that to be increased with glaucoma. So again, the aqueous humor is the fluid that flows between the iris, which is the front there, and in and around the lens back to the ciliary process. And so we need it to flow, and we need that angle to be open in order to flow in the right direction to not have fluid build up. So we'll be getting to more of that. It's a little bit hard to, show via audio without kind of showing you what I'm talking about as far as the arrows moving and whatnot. But we'll be getting to more of that. So this slide is actually better to show you that angle that I was talking about, the posterior chamber, and then that flow of movement. You see the lens, kind of around the lens, around that ciliary body, and around towards the iris. And so we want the fluid to be flowing in that direction, and we also want drainage of that. So if we don't have drainage, or we don't have flow, and the angle is too narrow or closed, then we would have either narrow angle glaucoma, either open or closed glaucoma, and we'll be talking about that. This is just the written slide of some of the A and P that we talked about. Again, just remembering that the optic nerve is our second cranial nerve, and that is responsible for transmitting the impulses from the retina to the occipital lobe of the brain. The sclera, of course, is our white part of our eye, and the cornea, which are that outer protective layer that I talked about. And the cornea is a clear fibrous covering that continues anteriorly from the sclera. It's vascular, and it is part of the refractive media of the eye as well. The middle vascular layer then is the iris. The iris is the pigmented area responsible for constriction and dilation to regulate the amount of light entering our eye. So when we do neural checks, we're checking that. The ciliary body is that whole anterior chamber, that middle section that maintains the intraocular pressure by producing the aqueous humor. So we'll be talking a lot about the aqueous humor, how much is being produced, and if it is draining properly. Some of our eye drops and medications that we use will decrease the amount of aqueous humor that is made. And then the choroid is the thin membrane that contains blood vessels to supply the eye tissue and is attached to both the ciliary body and the optic nerve. The inner layer then is the retina, and the retina is that thin transparent layer containing both rods and cones, responsible for vision in dim light or dark, which is the rods, and perception of fine details and brighter images, which is the cones. So the eye functions to receive the light's waves through the cornea. The waves are then refracted by the aqueous humor, the lens, and the vitreous humor, and transmitted ultimately to the retina. The images are formed and reversed by the convex lenses. So the rods and the cones of the retina transmit the light and then send that message to the optic nerve and to the brain's occipital lobe for the interpretation as vision. If you think about that very first picture we looked at, was looking at the receiving area for visual, and then the interpretation area of the vision, which is both in the occipital lobe. As far as assessment, we will intake information about their ocular history, such as any systemic condition and/or drugs that they may be on that may affect their vision. Certainly if they have diabetic retinopathy or other known ocular conditions such as cataracts, glaucoma, macular degeneration, etc. As far as the visual acuity, again, not necessarily in the hospital, but if we're at clinics or in other settings working with more specialized eye care, we'll be doing visual acuity. All students have done hearing and vision, so you have tested visual acuity via distance charts, either 10 feet away or 20 feet away, and gone through that. So hopefully that is that you're clear on how that is done. 20/20 vision, of course, is normal vision, or 10/10 if you're 10 feet away from that chart. The larger diameter, as far as, or the larger denominator equals myopia or nearsightedness. So nearsightedness means that you can see nearsighted and of course can't see far away. So 20/40, again, that bottom number is indicative of a referral. Near vision is measured with the Rosenbaum chart, and presbyopia is the technical word for farsightedness, or where you can't see close up. Otherwise, on our patients, we just routinely do a quick external eye examination. I mean, we can just see by looking at the patient, do we see any obvious discoloration, any jaundice of the sclera? Do we see any droopy eyelids? Do we see any obvious drainage or mattery, things like that? Those are all things that we're just visually looking for very quickly. We can do more of the measuring in the peripheral vision if you can think of optometrists or eye doctors where they start with their hand kind of behind your head and they kind of bring it to the side, and they want to know when you can see their finger. So basically just testing the peripheral vision that way. Extraocular muscle movements, there are basically 6 positions, and you'll see that on the next slide, that basically have them follow your finger to see that they are moving and the eye muscles are working. Ophthalmoscope, Again, we don't routinely do that on the floor or anything, but if you're working in a clinic at other setting, using the ophthalmoscope to basically assess for the red reflex, we want to see that. If you have an absence of the red reflex when looking through the ophthalmoscopes, that may indicate lens opacity. So the bottom picture is just showing the extraocular eye movements that we will be assessing for in all directions. And then the top part, of course, is showing the normal pupil and then how the pupils are going to constrict and how they are going to dilate. So miosis is pupil constriction. Mydriasis is pupil dilation. And you can see the D in the pupil dilation. So that's how you can remember the difference between those two. And we're also looking at both eyes to see if they are constricting and dilating both at the same time. This picture is just showing a couple conditions. The first top left is called ptosis. The P is silent, and this refers to a drooping of the upper eyelid. So sometimes in older patients it can be a problem. It can actually kind of block and interfere with vision. So that is a possibility that they'd have to have surgery for that. The middle picture is showing that exophthalmos, and I think it's a good reflection where you can see a lot of the, eye is outward and certainly could get dry, so they may need extra eye drops for that. Otherwise, ectropion and entropion is just showing different abnormalities of the lid turning in or turning out. And then the bottom right is that periorbital edema. So if you haven't seen it, it's just a very obvious puffiness around the eye. This slide basically just goes through the terminology for normal vision, the myopia, nearsighted, hyperopia, farsighted. The presbyopia that I mentioned already is the age-related farsightedness that we expect in many people, usually kind of around that 40 to 45 years of age. Astigmatism, there's an irregularity in the curvature of the cornea that can produce that. And then the blindness, and again, keep in mind with the definition or the technical correction for blindness is 20/200, but if you remember the eye chart, that 100 is that very top, very large letter. So again, there is, people can basically be legally blind before 2200 as well. Common causes of blindness: diabetic retinopathy, glaucoma, and macular degeneration, which we will be talking about. Normal age-related changes that we expect: decreased ability of the pupil to dilate. So this is what is contributing to decreased night vision and also increased light needed for small motor tasks. So it's very important if a person is reading, sewing, doing any of those things, those small motor, we need more light, and also just the difficulty that comes for people with like night driving and such. Decreased elasticity of the lens that makes near vision more difficult. Again, by age 45, typically most people will need reading glasses to see close up. Diminished tearing, there is more dryness that can expect as people age, and so there may be beneficial to just some artificial tears type eye drops that don't necessarily have medication but just add some extra fluid to the eye. Thinning and yellow conjunctiva, decreased peripheral vision, so we got to think of safety that way as well. Arcus senilis is the cloudy gray white, secondary to fat deposits. There's no treatment. It's just one of those kind of benign changes of aging. Increased incidence of cataracts and glaucoma, of course, with aging, and increased incidence of diabetes, which then can also damage the small vessels of the eye that nourish the retina. And diabetes is the leading cause of blindness, the diabetic neuropathy. Or excuse me, not diabetic neuropathy, but diabetic retinopathy. So next we're going to talk about some of the disorders. We're going to start with glaucoma. Glaucoma is basically an imbalance between the aqueous humor production and drainage. And remember that aqueous humor flows between the iris and the lens, and this nourishes the cornea and the lens. There's approximately 1 milliliter at all times that is made and reabsorbed at a rate of 5 mils per day. So what we're seeing with this disease is that there's either too much aqueous humor being produced and or there is a problem with the angle. So we need drainage that depends on an intact drainage system and an open angle, which that angle needs to be open between 20 and 45 degrees. So again, with glaucoma, the underlying problem therefore is going to be increased intraocular pressure that's caused by the increased aqueous humor, and ultimately that chronic or progressive increased intraocular pressure will cause optic nerve damage, and the optic nerve damage over time is what leads to the blindness. So normal IOP, remember, is 10 to 21. As far as glaucoma, there's really an unknown cause, although heredity and genetic predisposition is suspected. Blindness may result. It is progressive. There is no cure, but a lot of research continues with glaucoma management. Glaucoma risk factors are listed. Definitely increases with age, so greater than 40 years of age, greater in men than women as far as by gender. Otherwise, again, significant with family history, significant just with aging, prolonged use of steroids. We talked about that. That can also increase both cataracts and glaucoma. This is personally one of my favorite diagrams where you can see the actual angle better. So you can see my writing where I've labeled the lens and then the iris. So that fluid is flowing from the lens around to the iris, and you can see that angle. So do you see the angle there that is open approximately 40 degrees right now? And so that angle needs to be open, and we'll see where either we have closed angle or open angle glaucoma. So if that angle narrows, then there's going to be it's going to interrupt the amount of flow of the aqueous humor through that. The other thing is all of those little dark circles or ovals, I guess, that's called the trabecular meshwork, and that drains into the canal of Schlemm and episcleral veins, and that helps to get rid of fluid through that area as well. So the aqueous humor needs an open angle, but it also needs that drainage system to be working. So 90% of that aqueous humor is drained through the trabecular meshwork, and so we need that to be open to have adequate outflow of the aqueous humor. So again, an open angle, but also a trabecular meshwork that is open as well and draining. This is another good picture of what happens with glaucoma, and you can see the arrows showing how the aqueous humor is supposed to drain, and then that little hole is showing you the trabecular meshwork. So that's where 90% of that fluid is draining out of that area. And then also you can see where that angle needs to stay open. An open angle is 20 to 40 degrees. So when we get to glaucoma, where we have narrow angle or closed angle, you'll see that it is less than that 20 to 40 degrees. And here's another view. So there's several, so that hopefully you can connect and see the angle clearly and where that drainage system is supposed to be. Regardless of cause of damage, glaucoma changes typically evolve through stages. So this pathophysiology stage goes through what normally will happen. So there are some initiating events, precipitating factors that could include illness, emotional stress, congenital narrow angle, long-term use of corticosteroids, or mydriatics, which are the vasodilators that actually close the trabecular network. And if we have that closed, then obviously there's decreased aqueous humor outflow, and there's going to be buildup of pressure. So mydriatics are definitely contraindicated in patients with glaucoma. But that could be a triggering event, so could be triggered by pupil dilation. Then structural alterations in the aqueous humor occur of that outflow system. There are tissue and cellular changes caused by the above factors that lead to these structural alterations. And then functional alterations. So increased intraocular pressure or impaired blood flow create these functional changes that basically lead to the fourth stage, which is atrophy of the optic nerve. So optic nerve damage, atrophy, loss of nerve fibers, and loss of blood supply, which is why it's a progressive loss of vision. Open-angle glaucoma is also called chronic simple open angle, and this is the most common type. You will see most generally an increase of intraocular pressure over time, greater, around that 30 to 50 range. Again, remembering that 10 to 21 is the normal range. You will see loss of peripheral vision, mild headaches, more sensitivity to the dark, may have halos or difficulty focusing on near objects. So symptoms can be vague and symptoms can be gradual over time. Over time, with that increased intraocular pressure, there is going to be, continual damage and hypoxia to the retina and to the nerves. There's also going to be thickening or obstruction of the trabecular network, so that flow of the aqueous humor is obstructed or decreased. Again, remember, in open angle glaucoma, the angle is still open. So there is no closure of that angle, and you still have that 20 to 40 degrees. It might be narrowed, but it's not totally closed. Closed angle glaucoma is also called acute narrow angle. And this is where obviously is most severe. This is an ocular emergency. We have obstruction in the aqueous humor outflow due to complete or partial closure of that angle. So you'll see higher intraocular pressure, so greater than 50 to 70, and remember 10 to 21 is normal. So again, this could be triggered by pupil dilation, and because that pupil dilation closes the trabecular network and decreases flow. So symptoms that you would expect to see with closed angle or acute narrow angle, again, remembering it's an ocular emergency, the symptoms are going to be more severe. So severe eye pain and nausea, vomiting are the two that you're really watching for. Anytime you have severe eye pain and nausea, that is not normal, no matter what the condition is. So we're very concerned about that. Colored halos, lights, and the patient does need immediate treatment with miotic eye drops. The miotics, remember, are the constrictors, and those are going to open the trabecular network and allow outflow of the aqueous humor. As far as assessment and diagnostic finding, there's many things that they can do, and we don't have to be experts in all of this, but I just wanted to have you be familiar with some of the names of some of the tests they do for the eye. Tonometry is where they measure the intraocular pressure. Again, the normal IOP is 10 to 21. This basically determines they measure this by determining the amount of force necessary to indent or flatten a small anterior area of the globe of the eye. So you've probably had tonometry done where they did that little puff of eye at the eye doctor. Ophthalmoscope is where we're actually using the ophthalmoscope to inspect the optic nerve. So doctors and optometrists are going to be doing that. They can check for cupping of the optic disc. They can also see more pallor, and they can see the chronic hypoxia to those blood vessels. It is more basin-like as far as the shape. Gonioscopy is where they can differentiate between open and closed angle, so they can actually examine the filtration angle of that anterior chamber. And then perimetry is just assessing the visual fields, identifying which parts of the patient's central and peripheral visual fields have useful visions and which areas have been lost. And we'll see some pictures here in a second of these. So this is an example of the tonometry. The two pictures on the left are showing the gonioscopy, where they're using a device to actually see the angle of the anterior chamber and see where we're at as far as open versus closed glaucoma. And then on the right, bottom right, is just an examiner using the ophthalmoscope to visualize the retina. This slide is showing progression of the glaucoma visual change or visual field defects. So the black areas are the areas in the visual field that there has been damage to the optic nerve and there is no longer vision in those areas. So again, this is perimetry, and areas are mapped on a graph, and you can see over time, if you just go through A, B, C, D, E, and F, that we end up having all of that lost vision. So when you go to F, all they have left is just this small island of vision, so commonly called tunnel vision. The peripheral vision is lost. So as far as glaucoma management, this is a chronic condition. Of course, there is no cure. So the goal is really to prevent the optic nerve damage and just kind of slow the visual changes and the progression. So normal IOP again is 10 to 21, and the initial goal with glaucoma management would be to achieve an IOP of 30% lower than the current pressure. So they will be on lifelong medications and eye drops to help to lower the IOP. You'll need to spend some time looking at these medications. There are multiple categories of eye drops that I have listed here. If you look at the very first one, the cholinergics, those are the miotics. The miotics vasoconstrict. Remember, the mydriotics dilate, and there's a D in that mydriotic to help you remember the dilator versus the constrictor. So cholinergics or miotics, you'll have to know the classifications, but more importantly, which medications or which generic names would be examples of a miotic. So you've probably seen pilocarpine for sure. That is a pupillary constrictor and basically increases the outflow of the aqueous humor via opening the trabecular meshwork or network. All of the other ones, if you look at them, the adrenergic, the beta blocker, the alpha adrenergic, the carbonic anhydrase inhibitors, those all have an action of decreasing the production of the aqueous humor, and many of them also increase the outflow. So the actions are pretty simple. The cholinergics are going to constrict, and the other categories are reducing the production of aqueous humor. So if we can open up the trabecular network or meshwork and still decrease the amount of fluid being produced, that would be an ideal combination. So very common to see a patient on a pilocarpine eye drop, but then also on like timolol. I'm sure you've seen beta blockers. I'm sure you've seen that eye drop. Again, remember it ends in LOL. So that's how we know it's a beta blocker. It's still important to do the things that we normally do for beta blockers that we do when we're giving them for cardiac conditions, as far as checking the apical pulse, hold of less than 58. The other thing that we do for safety with the beta blockers especially is called punctual occlusion. This helps to decrease systemic effects. So that's where you put pressure kind of on the bridge of the nose where the lacrimal duct is, so that we can hold that eye drop and medication in the eye area versus it draining and then going systemic. So punctual occlusion for 1 to 2 minutes is the accurate technique for all eye drops, but especially important for the beta blockers. So again, the other one, the prostaglandin analog, the latanoprost, that is the same as Zolatin, and I'm sure you've seen that medication as well. So look those over, kind of become familiar with the names and the generics so that you can identify the medications used for glaucoma management. The other thing is make sure you understand that the mydriotics, the dilators, phenylephrine phenylephrine is an example of a dilator. That's going to close the trabecular meshwork, and so that is stopping the outflow of the aqueous humor, and therefore would increase intraocular pressure, which would be not what we would want to happen with someone with glaucoma. So people with glaucoma, if they're getting their eyes tested where you normally have to have the eye dilated, they would use extra precaution with that, or do an exam without actually dilating it. So this slide is very important because we need to refresh on how to accurately and properly give eye medications and eye drops. So besides the usual checking all of the rights 3 times, the name, the strength, the expiration, and all of that, looking at the bottle, making sure there isn't any, sediment or clumps and that it seems like a good color and clarity, all of those things are automatically being done. And we don't just check those, the name and dose and everything on the outside container, that holds the bottle. You need to be checking it directly on the bottle itself. The innermost packaging is where we need to do our right checks. As far as that, then we definitely need to be washing hands, and if we're teaching this skill to others, we need to make sure that they wash their hands, or their care provider or care loved one washes their hands prior to administering the eye drops. You don't ever want to be sharing eye drops. We don't want to touch the dropper top, obviously, with the lid. You're going to instill that drop or drops into the pocket of that lower lid. So you're going to pull down gently on that conjunctiva, and the drop is going to go there. Eyes basically kind of gently will close after, for about 1 minute after it's instilled. You can have them kind of gently do a few like drops. We don't want them to squeeze so tightly that they squeeze the drops right out of their eye. So if they can just gently close their eyes and open slowly and close, that helps to make sure that it's, kind of going back into the eye instead of coming out. And then the gentle pressure on the inner canthus, that punctual occlusion near the bridge of the nose, for 1 to 2 minutes. If you look in different textbooks, it may vary slightly on time, but 2 minutes is kind of the, 1 to 2 minutes is the extended, or the time frame that you will see consistently. Again, there is varying literature on how long to wait between eye drops, so anywhere from 1 to 5 minutes, depending on what source you're looking at. The main thing is that if you have a couple different eye drops, we can't just plop all the drops in. Your eye can only hold so many mils of fluid. So if you're putting them in, then they're just coming right back out, then obviously there is no point in that. So many patients are very educated about that, and they'll tell you that we have to wait a few minutes before giving the next drop, which is absolutely true. And then as far as if we have ointments as well, we don't see ointments very often, but you would instill the eye drops before applying the ointment, and then the ointments would be applied from the inner canthus to the outer canthus if you were applying the ointment. This is a really nice handout. This would be an example of what we also could use for patient education. I think the pictures are very clear and very simple instructions. So make sure that you feel comfortable, obviously instilling them yourself, but also educating about them. And then it also has a note on the bottom that if you wear contact lenses, that those need to be out. And then, typically they like you to wait 15 minutes after using your eye drops to put those back in. This is a nice acronym or visual, again, on the myotics versus mydriotics. The other way is the myotics, little word, little pupil, but the mydriotics, big word, big pupil, or otherwise I just say, you see that D right there in the mydriotic, and that's how you can remember that type of a medication is going to dilate. Now, give it, even though you can learn myotic and mydriotic, make sure you're learning medications, the drug names of those that would be a myotic versus a mydriotic. And this is just to remind you that there is a concept map in Iggy on the primary open angle glaucoma. Her concept maps really are good. It has a little history, it has the objective and subjective data, it has the expected outcomes, as well as several of the priority nursing interventions and safety. So always make sure you're looking at care plans and concept maps and all of those nursing alert box when you're doing your reading and studying. Another progressive eye condition is cataracts, and again, it's very common in people over the age of 65. You can see 50 to 70% of persons over the age of 65 will have a cataract or cataracts in their lifetime. So age is really a very big indicator. Also, long-term exposure to ultraviolet rays. So persons that don't wear sunglasses will develop cataracts sooner than those that are protecting their eye with sunwear. So that's a big one. Also, you remember steroids increase the incidence of both glaucoma and cataracts. So those are a couple of the really big ones. This is a progressive, again, development of opacity in the lens, resulting in loss of vision. Unlike glaucoma, cataracts, I mean, they're both progressive, but cataracts can be successfully treated. So here's a picture where you can see clearly the appearance of the eye that has the mature cataract and that gray opacity. As far as the cataract assessment, there will be gradual loss of vision, both close and distance. There is no pain. It's a painless, kind of blurry, hazy, cloudy-like vision is what patients will describe it as. Some patients will experience light scattering, kind of like flashes or sensitivity to glare, kind of annoying glare, light sensitivity. There may eventually be the absence of the red reflex as that opacity progresses, and they may have double vision. Now, again, opacity tends to occur bilaterally, but one cataract usually matures faster than the other, so they usually have a clear one eye or the other is the one that the eye doctor would encourage them to have their cataract fixed first, and then many people come back and have the second eye done, and oftentimes soon thereafter, within a couple months even. So if you're working in a surgical center, in a hospital, same-day surgery unit, you're definitely going to be taking care of patients that have cataract procedures. It's very prevalent and very common. It's a very short, I don't want to say easy, but pretty straightforward procedure that has had a lot of repetition and minimal complications. It's about a 25-minute procedure. They use just local lidocaine gel, so with this elderly population, it's very safe because they do not have to undergo general anesthesia. They typically are, there for 30 minutes before, go in for 25, 30 minutes of the procedure, and within 30 minutes to an hour of coming out, they basically have a ride home, and they encourage somebody to stay for the first 24 hours at home. So again, complications are uncommon. You can see the statistics there that 98% of patients that have cataract surgery have improved vision. So it's very, very successful. The most common is that third bullet, the extracapsular extraction. This is where they're going to remove the lens, the nucleus, and the cortex, and then they're going to put in the lens implant. So you'll need to know what to teach patients to expect preoperatively and, of course, postoperatively for cataract surgery. So a few things preoperatively, they will withhold anticoagulants and aspirin products for 5 to 7 days, but that's basically the same as any other procedure or surgery. Eye drops, there will be a series of eye drops if you're working in a pre-surgery area, and this is the one time where they don't really go by the rule of waiting, 2 minutes between drops, etc., because we are prepping them in a short period of time. So every 10 minutes, there are 4 different eye drops. So there's 4 different drops that are going in the affected eye and then in 10-minute intervals. So, you can wait maybe a minute or so before the next one, but you can't wait that whole 2 minutes or you won't be able to get all the eye drops in. So it's kind of busy getting all the eye drops and making sure that you're staying on schedule because, of course, you have other patients that you're taking care of as well. So they'll have a mydriatic, a dilator, they'll have an antibiotic eye drop, and then an anti-inflammatory eye drop. And they might have 2 different anti-inflammatory or 2 different antibiotic drops, so there's usually a total of 4, but those are the 3 categories that the eye drops are going to be coming from. We'll do almost all of our teaching, we do ahead of time, we do a home safety assessment, make sure that they have somebody able to stay with them, talk to them about lighting and cords and rugs and any of those fall risk trip hazards that would be pertinent for after their surgery. Postoperatively, we'll reinforce the education that we started preoperatively, but they will be wearing their glasses or a metal shield basically at all times, typically for those first several days. So many of them have glasses, so they'll just put their glasses on when they're up during the daytime. But in this picture, you can see where there is either a metal or now they're plastic, so you can at least see through them, but it's a shield that covers the eye. And that for sure will need to go on at nighttime to avoid unintentional injury while they sleep. There should not be eye pain, floaters, change in vision, flashing lights, or any of that after surgery. So if any of that happens, they would need to call the doctor immediately. What they can expect is a little bit of redness. So sometimes it looks like their eye is like a little bit bloodshot, if you will. And then also they will describe just some mild scratching sensation, almost as if you have a little bit of gravel, sand, or a little bit of something in your eye. So if you've been out kind of in a big windy day where you feel like you got a little dust or sand in your eye, that's kind of what it feels like, and that is normal. But eye pain, changes in vision, floaters, or anything like that would absolutely be abnormal, and when they need to call the doctor right away. They'll have lifting restrictions. They can't lift, push, or pull greater than 10 pounds, and that's usually for a 2-week time period. They can't do anything that will have a risk of increasing the IOP, so avoiding bending, or if they are bending, obviously bending at the knees and not bending at the waist. No swimming times 2 weeks. They can't be, in chlorine or in lake water or anything like that where they could be getting bacteria or germs into their eye. Of course, very good hand washing is essential throughout the day, and then all of the specific things that we talked about with accurate installation of their eye drops. Nursing diagnoses that we might expect with basically any of these visual changes, glaucoma, cataracts, or macular degeneration. There's the disturbed sensory perception visual. Anytime when there's vision or hearing changes or problems, we always think of injury or the potential for risk for injury. There's a lot of knowledge, a lot of teaching that goes with this on their eye drops, etc. So deficient knowledge and or impaired health maintenance. The next eye condition that we will talk about is retinal detachment, and a retinal detachment is an emergency as well. The retina is composed of multiple layers. The two innermost layers are the sensory retina, and then there is the epithelium. So this is where we have a separation of the sensory layer of the retina from the choroid, or that is the vascular layer. So in the next picture, you'll see that separation. And then when it separates, you'll have buildup of fluid and pressure between those separated areas. So some of the causes, trauma, there can be more of a genetic predisposition for this as well. Diabetic retinopathy will increase the likelihood or chance of a retinal detachment. Untreated hypertension, again, aging is really the most frequent cause. There's a shrinkage of that vitreous humor, which pulls on the retina at points of the attachment, which can have it or increase the probability of it pulling away. So this picture really does a really good job. You can see where the detached retina is. You can see the layers, the pink area line, and then the yellow. That yellow is supposed to be all the way up against that pink area. So that's the pink area is detaching the yellow area is detaching from that pink area. So fluid accumulates between the layers as a result of the trauma or degeneration that causes the initial tear and the detachment. So all of that fluid you can see goes in, and what would you expect to happen? Well, there's going to be an increase in intraocular pressure. I like the top pictures especially where you can see the normal retina and then the diseased retina. And I think you can kind of see where those layers, there's just kind of more of that pulling probability of that diseased retina where it could detach between the two layers, the choroid and the sensory layer. So separation of the sensory layer, which is the choroid and the vascular layer. The signs and symptoms of a detached retina definitely do look very different than glaucoma, cataracts, or macular degeneration. It is very much a sudden onset. There is no pain similar to the other disorders, but it's a very sudden onset of flashes of light, sparks, almost kind of like fireworks or like the sparkler things that you can use at 4th of July, shooting stars, they might describe it. There's floaters and increased in blurred vision. And then the other thing that is really specific to detached retina is there's basically a sense of a curtain being drawn or a veil coming down on their vision. So if you can just think of like a curtain on a stage, it's basically just coming across and then all of a sudden their vision is dark. So there's a nurse that I've worked with that's had this a couple times, and she said that's exactly how it happened, and it's just very, very sudden. There was just maybe a few flashes and then this curtain being drawn. So management of the detached retina, this would be irreversible if untreated. The immediate priorities for the nurse would be to patch both eyes. So whichever, it doesn't matter. I mean, obviously we need to know which eye is affected, but you will patch both eyes so that we can limit movement and prevent stress of both. They will be on complete bed rest. Right away, we need them in bed, and we need them to have that detached area dependent. So if it's a left eye that has lost the vision in a left eye detachment, the patient would be laying in bed, supine, but on the left side. So if you can visualize that picture where it's pulling away, if we put that left side down and dependent, at least that would prevent further pulling away and maybe even by gravity helping it to kind of push forward towards that other layer. So they need to be bed rest with the detached area dependent so that the gravity pushes the detachment closer to the choroid. We don't want any, forward jerking movements or head movements or anything like that. Keep in mind too, if we're pushing them on a surgical cart, they can't be bumping into things and jarring anything. We want to be very, very careful with that. So bed rest, eye that is affected is going to be dependent, so down. You'll be on that left side if it was the left eye. And then both of the eyes need to be patched. They will need, obviously, emotional support. It's very scary, and they'll need to go to surgery for repair. There will be afterwards some, a period of keeping their eye patched and limited reading and eye type activities for approximately 3 to 5 weeks, but the doctor will have specific instructions for them for after surgery.